So today's topic is about sedatives and hypnotics. Sedatives and hypnotics. These two category of drug, we call them CNS depressant. We call them CNS depressant. Means sedatives and hypnotic, both drug, they depress the CNS. They are mild and they are little bit strong. It means the activity, CNS depressant activity is dose dependent. That is your dose dependent. At low doses, we call them sedative, and if we increase the dose, then they will called as
आवाज
hypnotics. So
सर जी आवाज थोड़ी
both
रुक
are
के आ रही है।
अभी क्लियर है?
हाँ सही है, चलो।
Okay. So sedatives and hypnotics, they are CNS depressant drugs. They are CNS depressant drugs. Sedatives are or hypnotics. If we compare these two, then sedatives are equal to your half an hour lecture and hypnotics are nothing but your 1 hour lecture. In half an hour, we feel little bit sleepy. That is the sedative action. And in case of 1 hour lecture, normally we go to sleep. So similar to this, the low level of CNS depression is known as sedation, and the sleep inducing effect is known as hypnosis or hypnotic. So both are CNS depressant, and this is depressing the CNS at low doses, and this is something at high doses. So the CNS depressant action, if we look at normal physiology of our CNS. So this is the brain. This is our brain where we have one neurotransmitter that is known as GABA. This GABA neurotransmitter is responsible for CNS depression. It means whatever activities which are going inside the nervous system, this GABA will inhibit those activities. So this is the normal physiological molecule inside our brain, which inhibit the brain, which depress the brain. If we understand the normal physiological action of GABA, then we can increase its action and we can further depress the CNS. So how does GABA act? In case of CNS, suppose this is the neuron, this is one neuron, and this is another neuron. This is another neuron. From this neuron, what comes out? GABA. This molecule is normally present in CNS, and this neuron is having something called as GABA A receptor. In general pharmacology, we have seen GABA A receptor are your ionic or ionotropic type of receptors. It means these receptors are associated with some ion channel. Which ion channel? Chloride ion channel. Whenever GABA bind with the chloride channel, chloride will enter inside the cell and make the cell more and more negative. If you make a cell more and more negative, cell will hyperpolarize. Hyperpolarized means the action or action potential will be inhibited. Means if this neuron is releasing GABA on this neuron, then this neuron will be filled with negative charges. And the further from this to next neuron, the action will stop. So this is the normal physiology of the amino acid or the neurotransmitter GABA. So inside the brain, this was the neuron and this is your second neuron. This neuron releases GABA. And that GABA will act on the second neuron and it will lead to entry of a lot of negative charges inside the second neuron. So this second neuron will be loaded with the negative charges, and at this level the action potential will not transfer or propagated further, and it stops the action at this point. So we call that CNS depression. So the CNS depression effect of GABA is through chloride channel, that is your GABA A channel, which lead to negative charges accumulation inside the cell, hyperpolarization and inhibition of the signal further. This is normal CNS depression. So in pharmacology, we are using this mechanism for the benefit of our, like we have GABA type A channel in the neuron. We have GABA type A channel. They are nothing but your chloride channel. So we have some drugs like benzodiazepines. We have some drugs like barbiturates. These two category of drugs, they act through your GABA A channel, but the mechanism of action is different, but the ultimate result of both drug, barbiturate or benzodiazepine, is same. So what is the final result is loading the cell with negative charges. It means both category of drug, they increase chloride influx and that may lead to hyperpolarization and stop the function. But the mechanism, how does they act, is little different. This barbiturate, we call them GABA mimetic. GABA mimetic means when the barbiturate comes and it acts at the receptor, it allows chloride ion to enter inside the cell. So this mimic the action of GABA. So we call it GABA mimetic action. But if you look at benzodiazepines, they also act through GABA A channel. But benzodiazepine alone cannot open chloride channel. This is very important point. If you give barbiturate alone can open chloride channel. So barbiturate, they can open the channel, chloride enter, hyperpolarization, stoppage of inhibition of the CNS, depression of the CNS. So barbiturate, they can open, but benzodiazepines alone, they cannot open chloride channel. So how they are working? They are known as GABA facilitatory. It means they facilitate the GABA. This is the GABA. They help this GABA, or they facilitate, they help the GABA to bind at this place and open the channel. So itself benzodiazepine are not capable to open the channel. They help this GABA molecule to bind there and open the channel. So we call this action GABA facilitatory action. This is the main difference between these two classes of sedative hypnotic drugs. That one is mimicking, it mimics or it directly act at the receptor and open the receptor. But benzodiazepines, they cannot open this channel. So how does they work? How do they work? They help the GABA to sit or bind at the channel and open it, then chloride will enter. This is called GABA facilitatory action. And this is GABA mimetic action. This is the difference between these two class of drugs. The another difference with this GABA A channel, here we have barbiturates and benzodiazepines. The second difference is the first was facilitatory action and here it was GABA mimetic action. Second difference is they increase frequency. They increase frequency of channel opening and they increase duration of channel opening. Suppose this channel open for 2 milliseconds. Suppose the channel open for the 2 milliseconds. If we are using barbiturates, then they will increase the duration. Means from the 2 milliseconds, they will increase it up to 5 milliseconds. More duration. So more chloride will enter, inhibition of the action potential, depression of the CNS. So it increases the duration. But these benzodiazepines, they increase the frequency. See, 2 milliseconds is the duration. In this case, the duration remains same, that is 2 milliseconds. But this channel open for more number of times. More number of times. So this is the difference where duration of channel opening increases from 2 milliseconds. The channel will open for 5 milliseconds. It may open for 8 milliseconds, for 10 milliseconds. So more duration. But here the frequency. Frequency means number of times. Suppose it was opening for 3 times. Now it will open for 5 times, or 6 times, or 7 times. So number of times, that is frequency increases. In both the cases, end result will be same. That is, either you increase the frequency, more chloride will enter. Either you increase the duration, more chloride will enter. In both the cases, more chloride will enter, cause the depression of CNS. But the mode of action is different. That is, one is mimetic, one is facilitatory, one is increasing frequency, and this is increasing duration. So these are two differences between their mechanism of action. The third difference between your benzodiazepines and your barbiturates. In general pharmacology, we have seen dose-response curve. Dose-response curve. In case of benzodiazepines, the curve is like this. This is curve. Means the curve is flat. In case of barbiturates, the curve is more like this. That is steep. So what is the advantage or disadvantage with these two DRC? Suppose this is the point where sedation is achieved. Sedation, then hypnosis, then here anesthesia, and this is the point where you will find death. Similarly, sedation as for H, hypnosis, anesthesia, and death. See, the advantage with the flat DRC is this: if we increase the dose from the 2 milligram, if we increase the dose up to 10 milligram, at this much dose, means 5 times dose at 10 milligram, there will be anesthesia-like condition. But in this case, 2 milligram, and if you increase 4 and 10 milligram, if you increase the dose, you will find the case of death. So in case of benzodiazepines, more we increase the dose, the effect increases slowly. But in this case, barbiturates, with little or small increase in dose, the response increases very rapidly. The significance of this flat and steep curve is that these drugs are safe and these drugs are unsafe. In another word, in general pharmacology term, if you want to call it, flat DRC means they are safe. Safe means they have high therapeutic index. The drugs which are unsafe means they have low therapeutic index. It means suppose there is a patient of insomnia, means he wants to sleep. So hypnosis or sleep condition is present at this point. Suppose 3 milligram tablet. So if the patient takes 3 mg, he will go into sleep. But by mistake, suppose the patient on benzodiazepines takes 2 or more 3 tablets, that is 10 milligram. Then the patient will undergo anesthesia-like condition. But still the patient is alive. So if you increase the dose 3 times, 4 times, 5 times, still your patient is alive. But this facility is not present in your barbiturates. If the patient sleeps at 1 mg and you just increase to suppose 5 milligram. So with 5 milligram, the patient may end up into death or coma-like condition. So this is the disadvantage with your barbiturates. Little increase in the dose. If you increase the dose very little, then response increases very rapidly. Means with little dose increase, you will get a higher response. That is the bad effect. But in case of benzodiazepines, they are heavy, flat DRC. By mistake, if you have taken 3 or 4 times the dose, 3 or 4 tablets at a time, still you are alive. Will not go into phase of death. So they are safe and they are unsafe. And in general pharmacology term, the safety means high therapeutic index. Unsafe means low therapeutic index. So these were 3 differences in benzodiazepines and barbiturate. Then how to remember these 3 differences? There is very simple trick to remember these 3 differences. The channel is same, that is your GABA type A. Here you have benzodiazepines. benzodiazepines, and this side you have your barbiturates. So how to remember the three differences? In case of benzodiazepine, everything start with F. So very easy, you can remember benzodiazepines with the F. First F means GABA facilitatory. F means facilitatory action. Second F means they increase F for frequency of opening of channel. And third F means they have flat DRC. So this is your benzodiazepine. Facilitatory action, and opposite to this they have mimetic action, and they increase duration. And their DRC is steep. So these three differences are very easy to remember. The next difference between the benzodiazepines is this. Barbiturates are enzyme inducers. They are microsomal enzyme inducer. The trick in general pharmacology we have seen GPRS cell phone, where P was phenobarbital, means your barbiturate. So they are enzyme inducer. So what is the significance of enzyme inducer? They are having more drug interactions. Here, negligible or no enzyme induction. So, negligible to no drug interactions. So these are the four differences between these two. And the third is fifth difference. There is development of tolerance. But in benzodiazepine, no tolerance development. And the next is benzodiazepine, they have a specific antagonist. It means in case of overdose, you can give that specific antagonist to reverse the effect, and that is your flumazenil. But in case of barbiturates, they do not have a specific antagonist. So if there is excessive or overdose, or you can say poisoning of barbiturate, then how to remove that poisoning? So if a drug does not have any antagonist, in that case we use either urinary alkalinizer or urinary acidifier. Because barbiturates are acidic drugs, so what we use? Urinary alkalinizers. Make the urine alkaline. In opposite pH, the drug will ionize and it will removed or excreted through the urine. So in case of barbiturate, we make the urine alkaline. Why? Because these are acidic drugs. We make the urine alkaline and they will be removed through the urine. But in this case, we have antagonist. So, out of these 6 differences, if we see out of these 2 categories of drugs which are commonly used nowadays, so benzodiazepines nowadays commonly used, less commonly used. Why? Because they have high therapeutic index means they are safe. They have low therapeutic index, they are unsafe. Then there is no or mild drug interaction. Drug interaction. So we can use them because they do not interact with any other drugs. But these are enzyme inducers. So there is more drug interactions and they have specific antagonist. They do not have antagonist. There is no development of tolerance and there is development of tolerance. So these class of drugs, they have many advantages. They are safe, they have high therapeutic index, no drug interaction, no tolerance, and all these drugs are having so many disadvantages. So these days, we commonly use benzodiazepines as sedative hypnotic, not for other purpose. So if they ask in the exam that as a sedative hypnotics, which class of drugs are more commonly used than your benzodiazepines because of these following advantages or benefit. So inside the brain, what we have seen, we covered GABA. Normally the GABA depress, and we have seen two category of drug. One is barbiturate and one category was your benzodiazepine. Then inside the CNS we have something called norepinephrine. So we have adrenergic receptor inside the CNS, central adrenergic receptors. These receptors, they are involved in your pain pathways and they are involved in your pain pathways. They are involved in the arousal reflexes which make you arouse or active pain pathways. So if we inhibit this adrenergic system, then this arousal will end up into sedative action, and pain pathway if you block, that may enter into analgesia. So the drug which is having both property, sedative as well as analgesia, is your xylazine. That is nothing but your alpha-2 agonist, your adrenergic agonist. So next class of drug is our adrenergic system drug. So in the body where adrenergic receptors are present, as we have seen alpha-1 receptors in the blood vessels, so alpha adrenergic system. This alpha adrenergic, they are present in the brain, they are present in the spinal cord, they are present in the brain stem, spinal cord, brain, remember this brain stem and spinal cord. And outside this we have peripheral nervous system. So in the sympathetic nervous system, we have this alpha-2 receptor. And at other places like GIT and other minor quantity, we also have alpha-2. But this alpha-2 receptors, brain stem, remember the alpha-2 position, brain stem, alpha-2 spinal cord, this is your central nervous system receptors. And in the peripheral nervous system, we have sympathetic. Because parasympathetic is mainly your cholinergic system. That is your cholinergic system. But sympathetic is your adrenergic. So in sympathetic we have alpha-2. So to produce our desired action, that is sedation, we are going to inhibit or not inhibit, we are going to stimulate alpha 2 at the level of brainstem and at the level of spinal cord. Why we are stimulating the alpha 2 receptor? Why we are stimulating? See, this is the neuron and this is your G protein coupled receptor. G protein coupled receptor, that is alpha 2. This alpha 2 is linked with G inhibitory. G inhibitory means it will break down into alpha inhibitory and beta gamma inhibitory. This alpha inhibitory will bind with the adenyl cyclase, inhibit the action. It means the action was ATP to cyclic AMP. So that action will be decreased. But this unit अभी सही है?
बीच में थोड़ा स्टार्टिंग से करोगे वापस से, रुक दी थी।
हाँ थोड़ा बीच में बता दिया रुके।
तो वही ना, स्टार्टिंग से करोगे वापस से। अब सही है।
So alpha or mainly alpha 2 agonist. Alpha 2 agonist, like we have alpha 1, alpha 2. So alpha 1 are G stimulatory and alpha 2 are G inhibitory. If I stimulate alpha 2, then G inhibitory will be activated. It will inhibit the CNS. It means it will depress the CNS. So if we stimulate the inhibitory system, then the CNS will get depressed. So alpha 2 is inhibitory because it is linked with the G inhibitory type, G protein coupled receptor. So if you stimulate this, then it will stimulate this receptor and CNS will be depressed. So where these alpha 2 are present, these alpha 2 receptors, they are present. These alpha 2 are present, remember these two locations, at least brain stem. In the brain stem, there is one specific site which is called locus ceruleus. This is the locus ceruleus. At this site, alpha 2 receptors are present. And second site is your spinal cord. Spinal cord. Here we have alpha 2. So at these two locations we have alpha 2. The xylazine type of drug, ditomidine, all these agonists, they will come at these two locations in the brainstem locus ceruleus and at the level of spinal cord. Because the brainstem is the path, this is the path for some pain pathway. So if we block the receptors at this, that may lead to analgesia. So how this alpha 2 action is mediated in the brain stem? So in the brain stem, this is your neuron. This is your neuron which is having alpha 2 adrenergic system, and alpha 2 is linked with the G inhibitory type. As xylazine comes and stimulates the receptor, this will break down into two components, alpha and beta gamma, and both are inhibitory. This unit beta gamma partner, they open potassium channel. They open the potassium channel. So our cell are nothing but a bag of potassium. There is lot of potassium inside. So potassium will move outside the cell. So if you open the potassium channel, it means we are losing cation. We are losing cations. All the cations efflux outside. Then what is remain inside is the negativity. The neuron becomes more negative, means hyperpolarization occur, and that may lead to the inhibition of the neuron. So in this way, xylazine act on the alpha-2 receptor, activate the alpha-2. Alpha-2 is linked with G inhibitory. G inhibitory will break down into two components, alpha beta gamma complex. This beta gamma open potassium channel. All the positive potassium ion moves outside. Cell become negative, hyperpolarized and inhibited. So this is the mechanism of your xylazine, where through the alpha-2 it inhibited the CNS. But the more important about this alpha-2 mechanism, so this was the first mechanism of alpha-2. There is one more mechanism, that is through norepinephrine. In case of CNS, the role of norepinephrine is pain and arousal. If you inhibit or if you block the release of norepinephrine, then these two functions are inhibited. Arousal will become sedation, that is your sleepy, and pain will become analgesia. So xylazine produces both sedation and analgesia. How the norepinephrine is blocked, the release is blocked. In case of CNS, alpha-2 receptors, this is the presynaptic neuron. This is the presynaptic neuron. At the level of presynaptic neuron, we have alpha-2. And alpha-2, as you know, they are related with the G inhibitory. Here there is vesicle which is filled with the norepinephrine, and this G inhibitory will not allow this vesicle to release the norepinephrine. So it blocks the release of norepinephrine. So the postsynaptic receptors, they will not be excited. The message or signal transmission is inhibited at this level. So presynaptic neuron have alpha-2, and they are also called autoreceptors. They are also called autoreceptors. So presynaptic neuron in the central nervous system, they have alpha-2 autoreceptors which are linked with G inhibitory. They inhibit the release of norepinephrine. So if you inhibit the norepinephrine release, that may lead to sedation and analgesia. So this action is happening in the central nervous system. So we have seen two mechanisms. One is the block of xylazine. Two mechanisms we have seen. The first mechanism was related with the xylazine, that was your alpha-2. In both the cases, this was related with potassium channel opening. and the second one block release of norepinephrine. So by these two mechanisms, it gives you sedation and analgesia. In ICAR 2020, there was one MCQ that at the level of brain stem, which alpha 2 receptor is present? Which alpha 2 receptor is present? So this is your alpha 2A, alpha 2A receptor. The subtype is type A. So remember, for the sedation, the receptor is alpha 2A. So the sedative and analgesic action in the central nervous system is because of alpha 2A receptors. And these alpha 2 are present in mainly at the brain stem, where it is present locus ceruleus, and the second is your spinal cord. So this is alpha 2A subtype. One more MCQ that is related with your ruminants. They say ruminants are more sensitive, more susceptible to xylazine. Ruminants are more sensitive, more susceptible to the sedative effect of your xylazine. The question is why they are more susceptible. If you look at the ruminant, they require 1/10 of dose of horses. Means they are more sensitive and they are more susceptible. That is because of presence of alpha 2D receptor. So ruminant have alpha 2D receptor that makes them more sensitive to xylazine as compared to others. And other animals, if they ask for other animals at the level of brainstem, at the level of spinal cord or brainstem, remember the alpha 2A. And if they ask for the ruminant, why they are more sensitive, answer will be alpha 2D. So for ruminant, remember alpha 2D, and for other animals, the sedative action alpha 2A. So these three class of drugs, sedative, if you increase the dose, they become hypnosis. Means they will give you sleep, and that is your mild sedation. So we have done with benzodiazepines, then we did barbiturates, and the third alpha 2 agonist. So these are the three main or major class of drug from where they ask you the MCQs, and the other are nothing but some miscellaneous like your chloral hydrates, some other class of drugs. But these three are very important. These two, they act through your GABA type A. And they alpha 2, remember, for others alpha 2A, and for ruminants alpha 2D. That is very important. Benzodiazepines are GABA facilitatory. Barbiturates are GABA mimetic. In both the cases, they open the chloride channel, what comes in chloride, and they depress the CNS. Alpha 2, they open the potassium channel or they inhibit, block the release of norepinephrine. They produce the sedation or analgesia. And in brainstem and spinal cord, remember alpha 2A for sedative analgesic action, and for ruminant, why they are more sensitive? Alpha 2D. This alpha 2A was asked in the exam, and alpha 2D may be your future MCQ for ruminant, alpha 2D. Benzodiazepines and or out of these two, nowadays which are commonly used as a sedative or hypnotic, your benzodiazepines. Why? There are so many advantages. They are safe, no tolerance, no drug interactions, specific antidote is there, and many others. So this finishes our sedative hypnotic topic. In the next, we'll cover tranquilizers. First, we'll see sedative hypnotic versus tranquilizers. They calm the patient and they depress the patient. So in next class, we'll see the difference and then their mechanisms and some example like acepromazine, which causes penile prolapse in horses, ICAR net 2021.